Good afternoon, everyone. I'd like to thank the organizers for inviting me to speak today on the topic of patient-reported outcomes in HIV. Here are my disclosures. So I'd like to start by reminding us of a common scene that illustrates, I think, quite well why patient-reported outcomes are important. Here we have an HIV clinician who's reviewed their patient's most recent blood work and reports, "Great news, you've achieved viral suppression. You're responding really well to antiretroviral therapy." But meanwhile, we see the patient who's thinking, "This diagnosis has affected my whole life. I'm having trouble sleeping. I feel tired. I'm getting headaches." So we understand that these concerns are perceived as relatively minor by the physician in the scope of her larger healthcare needs. However, they remain important to the patient and often his or her quality of life. So unlike standard clinical outcomes, like viral suppression, like mortality, patient-reported outcomes can provide us with unique insights into how care or given therapy can affect a patient. They lead us to be more focused on the real benefits that patients seek to help us overcome asymmetries in doctor-patient communication. So our ability to make use of these insights can affect not only individual patient care, but also the quality of care that we deliver to patient populations. So patient-reported outcomes, or PROs, are defined as any report of the status of a patient's health condition that comes directly from the patient, without interpretation of the patient's response by the clinician or anyone else. A PROM, or a patient-reported outcome measure, simply refers to the tools that we use to capture the PRO's information directly from patients. PROMs can either be generic or disease-specific. Generic instruments enable us to compare across patient populations. However, some of these are not sensitive to specific domains that might be especially important to a given patient population. So you may already be familiar with the use of patient-reported outcomes in clinical trials, as these measures were initially developed as secondary endpoints. However, today I will draw your attention to a different application of patient-reported outcomes, their use in clinical practice. So here, this taxonomy that was provided and developed by Greenhall and colleagues shows us that patient-reported data can be used at the individual and the group level, and can also be used in the clinician-patient interface. So here we see at the individual level, patient data can be used to screen, to monitor, and to promote patient-centered care. It can also be used to facilitate communication with an interdisciplinary team. Aggregated PROMS data can be used for shared decision-making and population monitoring and assessing quality of care. It can also inform service design and redesign. So I think that the environment has become increasingly conducive. However, it's not without challenges. In the last 20 to 30 years, we've seen HIV care evolve immensely with the normalization of life expectancy, and now we're in a chronic care model. We've also seen new tools to measure patient-reported out data and new methods as well, like item response theory. The infrastructure has also changed and has evolved in our favor. With computing, we can now use tablets and web applications, electronic health records, to help us and capture patient-reported data and also process it almost in real time. The regulatory environment is also conducive to the application of patient-reported outcomes in clinical care. As we see demands from authorities, institutions, clinicians to measure and demonstrate improved outcomes at the individual service and health systems level. So how are PROs measured, and what makes a good PROM? So the easy answer is that PROs are measured using questionnaires or instruments, and we expect these questionnaires to have sound measurement properties. We want them to be valid. We want them to measure what they're purported to measure. We want them to be reliable. In other words, we want to do this in a consistent fashion. We want them to be responsive. We want to see evidence that they are able to capture clinically meaningful change. And finally, interpretable. Now, this point, along with the point of logistic feasibility, is especially important if we want to achieve the integration of patient-reported data at all levels of healthcare. And we have to ensure that the tools that we're selecting can be easily administered and do not overburden either the patients or the clinicians. And we have to ensure that the scores that we're generating can be interpreted by different stakeholders, be they clinicians, patients, or healthcare administrators. So, are there measures available in the field of HIV? Now, our colleagues Kim Engler in Canada did an amazing inventory of 117 HIV-specific PROS instruments that covered 12 different concepts. One of the most prominent concepts was health-related quality of life, where they identified 23 HIV-specific instruments. Art and art adherence was also prominently represented among the HIV-specific PROMS, with 19 different instruments identified. When we talk about health-related quality of life, a common patient-reported outcome, we see in 2017 that Vanessa Cooper and colleagues published a systematic review of reviews in which they tried to identify and especially really to narrow down which tools, which of these HIV-specific instruments designed to measure health-related quality of life were actually able to be administered in less than 10 minutes, meaning they were feasible, they had been developed with input from people living with HIV, and they were sufficiently comprehensive. And then they further specified that for generic scales, there had to be available normative data. So these colleagues were able to identify 9 generic scales and 7 HIV-specific scales, so 7 among the 23 that were also identified by Engler and colleagues. So we concluded that there was really an absence of a gold standard here, that the choice of the scale is often a function of a specific research question and the end use, but that Cooper and colleagues pointed to 2 newer scales, at least for the measure of health-related quality of life, which were promising, but often these scales needed further validation, especially if they were going to be administered in new populations or in new target languages. So this is also more recent work by Cal and colleagues in the HIV series on HIV outcomes, where colleagues pointed to a number of different generic or HIV-specific tools that could be used to measure health-related quality of life, patient empowerment, or other PROMs of interest. I'd like to draw our attention quickly to a PROS that was developed rather recently by our colleagues in France. The Proqual HIV is one of the newer instruments designed to measure multidimensional health-related quality of life. Here we see that energy, sleep, coping, these were the newer themes that emerged from extensive qualitative research conducted across 9 different countries in the mid-2000s. And we should be considering what themes are relevant for care today. And this brings me to my next slide. So we see that there are instruments that are available, but are they all relevant? And I think we should be asking ourselves the following questions. Why were they developed? Were they developed to assess immediate response to antiretroviral therapy in the late 90s? Were they developed using in patient populations that no longer reflect those currently in care today? Another quite provocative question is, do we really need HIV-specific instruments? And this is a question that emerged from the validation of the Proqual HIV breath in a population where the 90-90-90 targets had been achieved. We noted that 2 of the domains showed poor or less than optimal internal consistency, and this might have been due to some of the HIV-specific items that might no longer be relevant in those who are in Europe and potentially very well cared for. So the last point is, when we're validating these new instruments, we're interested in their ability to detect clinically meaningful change. Now in HIV, historically, we've seen that as achieving viral suppression or seeing CD4 cell counts increase, or different HIV stages based on the CDC clinical categories. Now, this is going to be increasingly difficult if we're talking about chronic HIV care, where we expect fewer and fewer people to actually progress to advanced disease. So I wonder, how do we validate new instruments in populations where fewer and fewer people are expected to experience advanced disease? Now, going back to the integration of HIV, of PROMS into HIV care. So in the work that I'm involved in Bordeaux, integrating electronic and paper patient-reported outcome measures into routine HIV care and using the ANRS CO3 ACI-10 cohorts data capture and visualization system to do that work, we published this protocol in 2018 where we described the steps where we selected what instruments we were going to use and how we developed and tested the instrument to see if it was going to be feasible. We concluded this paper by reflecting on how we hope to move forward with this work, namely to integrate these measures into clinical care. And we developed this conceptual framework where we described that the provision of this information to clinicians might result in changes to doctor-patient and communication. This is what I presented in the first slide. Now, these changes to doctor-patient communication might influence the way in which clinicians monitor treatment. It also might result in the early detection of unrecognized problems. We see that the early detection of unrecognized problems might lead to changes in the clinical management of patients. For example, the referral to a specialist, further testing, more individualized advice on management, which ultimately could lead to improved health outcomes. Monitoring treatment response could also lead to changes in patient behavior, and this is something that I think we're all struggling with when we consider what long-term HIV care looks like. So of course, we think of adherence to ART, but not only. We're thinking about tobacco suppression, tobacco cessation, physical activity, maybe weight management, or different interventions that are preventative that could become part of standard HIV care. Now, the proximal mechanisms here are changes to patient health behavior and changes to clinician management. And we expect that those have to occur in order for patient satisfaction or improved outcomes to be achieved. But as you see from this slide, the mechanisms are extremely complex, and we have to consider this as we further integrate this data into HIV care. Now, this work is really ongoing, and I wanted to highlight the work being done in the United States by pioneers at the University of Washington. Now, they've began, as we have in Bordeaux, integrating the provision of patient-reported data that was initially collected for research into routine care. So they have patients complete a PROS data battery while they're waiting for their HIV consultation, and they do this at every single consultation. And at the time that this work was beginning, that was as frequently as every 4 to 6 months. The content of the PROS battery is focused on a depression screening, an ART adherence screening, substance abuse, and HIV risk. And in this later work, they compared medical records documentation and intervention before and after PROMS were shared with clinicians, and when and if a clinically relevant depression or risk was reported. And they found that providers increased their documentation of depression, of at-risk alcohol use, of substance use, of inadequate adherence once they were provided with this additional PROS data. However, not all of these areas were followed up. Clinicians tended to follow up depression and inadequate adherence, but at-risk alcohol use or substance use were neglected. So this needs to be really considered as we think about the goals of these tools. So to conclude, PROS data have a really important and potential role to play in HIV care. And although response to treatment may not be our primary concern, early detection of unrecognized problems and behavior change certainly are. There's still no consensus about the best PROM measure, and at least for health-related quality of life, We definitely have challenges when it comes to responsiveness and interpretability, and whether or not we should favor unidimensional or multidimensional PROMS. So the last point is, when do we administer these instruments in the context of chronic disease care? And how do we ensure that the infrastructure is conducive and that space is made for these assessments? And how do we facilitate interpretation by clinicians? Finally, I think that this conference and other efforts are extremely important for creating buy-in from all concerned parties, because we need to show and consistently demonstrate that these tools have value, and that requires additional evaluation. I look forward to getting your questions, and thank you very much for your attention.